Hand over the mic to Professor Rai Chaudhary.
So, yes, it's 11:40. So, after the morning session, as you know, this year the program has been changed to a different module where it's all going to be very practical oriented discussion, primarily for how to face your practical examination. And you have already had the first session, and as you know, chronic otitis media is the most likely case that you are given in a long case in your MS or diploma examination. And the next important case is going to be a chronic rhinosinusitis kind of scenario. So, in the next 2 hours we are going to discuss briefly two cases. One is going to be a chronic rhinosinusitis kind of situation, and the second one is going to be a unilateral sinonasal mass, so that most of the rhinology will be covered. We will spend more time discussing the history, clinical methods in the first case, which most of the things will be covered in the first case, and during the second case we will probably just touch up on the management algorithm, because otherwise history and clinical examination is same for any rhinology case as such. So, we are going to present this case, which is a case of 26-year lady who is a married lady who presents with a right sided nasal obstruction for a duration of 12 months and associated with thick nasal discharge and occasionally blood stain on blowing the nose, which can happen to anybody. So, please note that blood stain only on blowing the nose, but not a bloody nasal discharge. Occasionally and frequent headaches the patient has, and in the recent past 1 month or so the patient is having smell disturbance as well, which can be hyposmia or anosmia, and patient does not complain of any visual disturbance. We are not going through the formal history of present illness or anything. This is just a case capsule for us to discuss. So, associated nasal discharge, it is almost showing the same thing. Initially the discharge was mucoid, non-purulent, non-founciling and not blood stain, and headache is there, no fever, and it is intermittent because there are episodes of exacerbation and relief, and no visual disturbance, and patient does not have any bleeding disorder history. Just because the patient gives a history of blood stain on nose blowing, that is why that history is important. And these are the past history, I think, which our colleague will discuss, nothing much, and the examination. I will just give you the salient features that we have in the patient. Primarily the patient has a right nasal cavity pale and polypoid mass, which is filling the entire nostril for us to obscure the entire nostril, and the septum is deviated to the opposite side, which is the left side, and mass was soft in consistency, could not be probed because obviously the mass is quite presenting at the anterior nares, and it is a pale and polypoid looking mass and does not bleed to touch. These are the most important salient features of the mass that is there, and that cold spatula test, obviously the right side there is no misting, and ear, nose, throat, and ear and throat is. In addition, the patient has slight proptosis on the right side, which is the affected side, but ocular movements are normal. Patient does not have any visual disturbance, and color vision obviously is not checked at the bedside, but we will discuss about how to check all these things. And I think you would be able to come to a diagnosis the moment you look at this scan, which will be discussed in much detail in the next 1 hour. So, unilateral nasal opacity, which has got hyperdensities, and the septum is pushed to the other side, but there is no bone erosion, there is some amount of bone expansion over there. So, this is a right sided sinonasal polyposis, we think, because of the history and everything. So, how to deduce to this diagnosis and how to go to the differential diagnosis, our next speakers will come and take over. May I invite Dr. Deeptangshu to come and take over the history?
স্যার তার আগে একটু জেনারেল কথা বলে নি।
Of course.
তোরা অল আর ইউ এক্সামিনি ব্যাচ, তাই তো মেজরিটি, আর ইট উইল বি লং কেস। লং কেস কি থাকতে পারে? ইট মে বি এ পলিপ, ইট মে বি এ সিম্পল কেস অফ পলিপোসিস, অর ইট মে বি এ কেস অফ সাইনোনেজাল মাস। ফার্স্ট হচ্ছে আমাকে আইডেন্টিফাই করতে হবে ইট ইস এ কেস অফ পলিপ অর মাস। দেখ নিজেদের সেন্টারে এক্সাম হবে, ইউ নো এভরিথিং অ্যাবাউট দ্য কেসেস, ঠিক আছে, বাট ইউ হ্যাভ টু প্রেজেন্ট প্রপারলি আর ইউ হ্যাভ টু রাইট প্রপারলি, কারণ ইউ আর গিভিং পোস্ট গ্র্যাজুয়েট এক্সামিনেশন MS। আর তোরা সবাই খুব ভালো করে পড়াশোনা করেছিস, এবার তো ভালো ভালো নিশ্চয়ই তোরা পাবি, ভয় পাস না, নিজেদের কলেজ ভালো করে লিখবি, কিন্তু ইউ হ্যাভ টু মেনশন দ্য পয়েন্টস ইন হিস্ট্রি ক্লিনিক্যাল এক্সামিনেশন, কারণ এক্সটার্নাল যে এক্সামিনার আসবে তার হতে পারে হঠাৎ একটা পয়েন্ট মিস করলি, সেটা নিয়েই তোদের কোশ্চেন শুরু হয়ে গেল, তো এই পয়েন্ট লিখতে হবে। এবার স্যার যে বলছেন চিফ কমপ্লেন হচ্ছে 26 ইয়ার ফিমেল ম্যারিড প্রেজেন্টেড ইন এপ্রিল 2024 উইথ দ্য চিফ কমপ্লেন দুটো থাকতে পারে না আমাদের নেজাল মাসে, ওয়ান ইজ দ্য নেজাল ডিসচার্জ, ওয়ান ইজ দ্য নেজাল অবস্ট্রাকশন। ইন দিস কেস সাপোজ দেয়ার মে বি পেশেন্ট তো অনেক বলে, তোরা লাস্ট 3 ইয়ার্স ধরে দেখেছিস পেশেন্ট অনেক বেগ কথা বলে, কিন্তু চিফ কমপ্লেনে যেভাবে ইউ উইল প্রেজেন্ট দ্য হিস্ট্রি অফ প্রেজেন্ট ইলনেস সেই পয়েন্টগুলোই লিখতে হয়। সাপোজ স্যার এখানে একটা লিখেছেন দেখবি অকেশনাল ব্লাড স্টেন অন নোজ ব্লোয়িং, সো ইট ইজ এ ইম্পর্টেন্ট পয়েন্ট, নেজাল ডিসচার্জ উইথ ব্লাড স্টেনিং আছে কিনা। থার্ড আরেকটা হাইপসমিয়া মানে ডিস্টারবেন্স অফ স্মেল ফ্রম লাস্ট, এবার প্রত্যেকটা ডিউরেশন লিখতে হবে, তো অবভিয়াসলি একটু মাথায় রাখতে হবে যে নেজাল অবস্ট্রাকশন ফ্রম 2 ইয়ার্স, হাইপসমিয়া ফ্রম লাস্ট 6 মান্থস, কোনোভাবে যেন উল্টো না হয়ে যায় যে পেশেন্ট বলছে আমি আগেই গন্ধ পেতাম না ছোটোবেলা থেকে, আর আমি নেজাল ডিসচার্জ আর নেজাল অবস্ট্রাকশন লিখছি ফ্রম লাস্ট 6 মান্থস ধরে। অনেক সময় পেশেন্ট এটাও বলতে পারে স্যার আমার তো নাকের মধ্যে পলিপটা আছে, সো দের ইজ আ মাস কামিং আউট ফ্রম দ্য নেজাল ক্যাভিটি। তোরা হিস্ট্রি টেকিং জানিস, তো আমি জাস্ট তোদের ইম্পর্টেন্ট স্যালিয়েন্ট পয়েন্টগুলো বলছি। স্যার নেক্সট স্লাইড। দেখ এখানে ভীষণ ইম্পর্টেন্ট নো ভিশন ডিস্টারবেন্সেস, তাহলে এটা আসবে হচ্ছে হিস্ট্রি অফ প্রেজেন্ট ইলনেস। তাহলে হিস্ট্রি অফ প্রেজেন্ট ইলনেসে কী হবে, দ্য পেশেন্ট ওয়াজ অ্যাপারেন্টলি ওয়েল 2 years ago, নেজাল ডিসচার্জ ক্যারেক্টারিস্টিক বলতে হবে নেজাল ডিসচার্জের, স্যার এখানে কি লিখেছেন অ্যাসোসিয়েটেড উইথ দ্য নেজাল ডিসচার্জ ফ্রম অন দ্য সেম সাইড, সাপোজ ইট ইজ রাইট সাইড, occasional blood stain, so এই occasional blood stain on nose blowing or it is a blood staining nasal discharge, এটা ভীষণ ইম্পর্টেন্ট। সাপোজ কেন বলছি, এনি নেজাল ডিসচার্জ উইচ ইজ ব্লাড স্টেন সবসময় কি ম্যালিগনেন্সি হয় না, এনি ইনফেক্টেড পলিপ হতে পারে, অথবা জোরে নোজ ব্লো করেছে তার জন্য হতে পারে, তো প্রথমেই স্যার বললাম যে ইট ইজ এ ব্লাড স্টেনিং নেজাল ডিসচার্জ, সো সেটা ইট ইজ এ কেস অফ ম্যালিগনেন্সি, তখন কিন্তু ক্রস কোয়েশ্চেন হবে, তাই এটা মাথায় রাখতে হবে যে আমার ইনফেক্টেড পলিপও ব্লাড স্টেনিং ডিসচার্জ হতে পারে অন নোজ ব্লোয়িং। ইনিশিয়ালি মিউকয়েড, নন পুরুলেন্ট, নন ফাউল স্মেলিং, নন ব্লাড স্টেন, তো এখানে কিছু নেগেটিভ হিস্ট্রি আছে, আমাদের ইয়ার কেসের মতো ইট ইজ অলসো ইম্পর্টেন্ট টু পুট সাম নেগেটিভ হিস্ট্রি, so from the history we can differentiate, say it is not a case of nasal mass or sinonasal malignancy, so it is a case of benign disorder, like it may be a case of polyposis or any benign pathology. Now what is the type of discharge, intermittent or continuous? You will not get any patient with CSF rhinorrhea or any patient of nasal mass or polyposis with intracanal extension, তো ওদের থাকবে না, সেই কেসগুলোকে আমরা অ্যাভয়েড করি লং কেস হিসেবে দেওয়ার, তাই জন্য তো ক্লিয়ার কাট কন্টিনিউয়াস ওয়াটারি ডিসচার্জ হলে তখন তোকে বলবি, যদি এটা CSF রাইনোরিয়া হয় তোদের ওখানে তোরা থিওরিটিক্যালিও পড়েছিস CSF রাইনোরিয়া শর্ট নোট আসতে পারে, তো কী টেস্ট করবি কীভাবে, থিওরিটিক্যাল কোয়েশ্চেন চলে আসবে। নাও নো হিস্ট্রি অফ ফিভার, হেডেক উইল বি দেয়ার অবভিয়াসলি, যে কোনো সাইনাসাইটিস হলেও হেডেক আছে, তো এখানে এই পেশেন্টটার পলিপোসিস আছে, তো হেডেক তো থাকতেই পারে। এবার হেডেক নিয়ে অনেক রকম কোয়েশ্চেন জিজ্ঞেস করতে পারে, কী টাইপ অফ হেডেক, ইট ইজ এ ভ্যাকিউম হেডেক আর টেনশন হেডেক, ইট ইজ এ স্লাডার নিউরালজিয়া, এগুলো তো তোরা জানিস আন্ডার গ্র্যাজুয়েট টপিক, এটা মাথায় রাখতে হবে যে যদি বাই চান্স জিজ্ঞেস করে যে হেডেকটা কেন হয়েছে, তো আমি যেন বলতে পারি। এবার নাথিং সাজেস্টিভ অফ এনি ব্লিডিং ডিসঅর্ডার, নো ভিজুয়াল ডিস্টারবেন্সেস, ভিজুয়াল মনে কর দ্য ফার্স্ট কেস উইচ উই আর প্রেজেন্টিং নাও ইট ইজ এ সিম্পল কেস অফ দ্য নেজাল পলিপোসিস, এরপরে আরেকটা কেস স্যার প্রেজেন্ট দেবেন, সেটা হচ্ছে সাইনোনেজাল ম্যালিগনেন্সি, তো আমরা তোদের লং কেস হিসেবে আগে কী দিতাম সাইনোনেজাল মাস, তোরা জানিস COM আসবে, সাইনোনেজাল মাস আসবে, থাইরয়েড আসবে, ল্যারিংস আসবে, এবার শর্ট কেসেও আসতে পারে ঘুরে গিয়ে। সাইনোনেজাল ম্যালিগনেন্সি যদি না পাওয়া যায়, এখন এই সিম্পল কেস অফ AFRS উই ক্যান গিভ অ্যাজ এ শর্ট কেস, তো ওটাকেও প্রেজেন্ট করতে হবে ধরে নিয়েই, কোনো সাইনোনেজাল মাস মানে প্রথমেই ডিফারেন্সিয়াল ডায়াগনোসিস স্কোয়ামাস সেল কার্সিনোমা, অ্যাডিনোকার্সিনোমা, অ্যাডিনোসিস্টিক কার্সিনোমা, এটা না ভেবে অলওয়েজ ট্রাই টু থিঙ্ক দ্যাট ইট মে বি এ কেস অফ সাইনোনেজাল পলিপোসিস আর AFRS এর কেস হতেই পারে। এখানে স্যার যেটা বলছেন নো সাজেস্টিভ অফ ভিজুয়াল ডিস্টারবেন্সেস, সো ভিজুয়াল হিস্ট্রি ইজ ভেরি ভেরি ইম্পর্টেন্ট ইন হিস্ট্রি অফ প্রেজেন্ট ইলনেস। তাহলে কী কী জিজ্ঞেস করবো, ভিজুয়াল অ্যাকুইটি, ডিপ্লোপিয়া আছে কিনা, ডাবলিং ভিশন, কারণ এনি সাইনোনেজাল ম্যালিগনেন্সি উইচ ক্যান ক্রস দ্য অরবিট অর ফ্লোর, so it can cause ophthalmoplegia. Field of vision on examination, clinical examination, Shubroto sir will tell you, the field of vision important. Or any sinonasal malignancy or mass or polyp can also extend, it can give pressure or erode the lamina papyracea, it may be intraorbital. So একটা separate আলাদা পয়েন্ট করতে হবে হিস্ট্রিতে, there is ক্যাপিটালও লিখতে হবে, there is no history of visual disturbances, no history of double vision, there is no pain, অনেক সময় there may be pain থাকতে পারে, তো there is no pain in the eye. Visual history পর স্যার চেঞ্জ, পাস হিস্ট্রি এখানে লেখা আছে দেখবি, there is no past history of hypertension, no history of any allergy. এটা পাস হিস্ট্রিতে না করে হিস্ট্রি অফ পার্সোনাল হিস্ট্রিটাও করতে পারিস, অ্যাজ ইট ইজ এ কেস অফ সাইনোনাল পলিপোসিস। সো দেয়ার মে বি সামটাইমস, তোরা যদি কোনো পেশেন্টকে জিজ্ঞেস করিস যে আপনার কোনো অ্যালার্জি ছিল, অনেক সময় মেজরিটি কেসে বলবে আমার কোনো অ্যালার্জি কিছুতে নেই, অথবা ফুড অ্যালার্জি বলবে, কিন্তু কিছু ক্ষেত্রে অনেক সময় দের মে বি হিস্ট্রি অফ অ্যালার্জি, দের মে বি হিস্ট্রি অফ পেশেন্ট অ্যালার্জি টু ফুড বলতে পারে, অ্যালার্জি টু ডাস্ট বলতে পারে, অ্যালার্জি টু পোলেন বলতে পারে। তো মেক এ স্যালিয়েন্ট পয়েন্ট ইন ইয়োর ফিচার্স, কারণ ইন ফিউচার তুই যদি সাইনোনেজাল পলিপোসিস হিসেবে প্রেজেন্ট করতে চাস, তো এই অ্যালার্জি হিস্ট্রিটা উইল বি এ পজিটিভ পয়েন্ট। নো হিস্ট্রি অফ এনি পাস সার্জারি, পাস সার্জারি কেন ভীষণ ইম্পর্টেন্ট ইন কেস অফ ইন্টারমিডিয়েট লিশন, লাইক ইনভার্টেড প্যাপিলোমা, মনে কর ওর পাস্টে কোনো পলিপ ছিল, বাইরে কোনো কোয়াক ডাক্তার বা কোনো কোথাও করেছে, পলিপেক্টমি করে ছেড়ে দিয়েছে, কোনো বায়োপসি করেনি, দের হিস্ট্রি অফ পাস, there is a history of মনে কর সার্জারি, আর নাও পেশেন্ট প্রেজেন্টিং উইথ দ্য polypoidal mass. So inverted papilloma, you have to keep in mind that there may be chance of inverted papilloma, so history of surgery is very important. History of head injury is very important in post graduation, specifically in case of COM. Now there is a family history, no history of similar type of disease in his or her family members. Personal history te there is a mixed diet, এগুলো তো তোরা লিখিসই। Now specific history, that there is no history of exposure to specific dust or fumes, because wood dust, nickel, formaldehyde, they are the category 1 risk factors in case of sinonasal neoplasm. So you have to mention what is the occupation of the patient. In history, in case of sinonasal any disease, so occupation is very important. Sir, next. Now it is a general examination. The history te first chief complaint, you try to be within 2 or 3 points: nasal obstruction, nasal discharge, history of blasting discharge, hyposmia or headache. Not more than that. On history of present illness, you write the elaborate history on the chief complaint with a negative history of no history of if headache, fever, blood staining, neck rigidity, anything, ophthalmoplegia, doubling of vision, negative history. After that, family history, personal history, try to maintain. In case of polyposis, there is a history of dust, or if there is a history of pollen allergy, or in case of sinonasal neoplasm, what is the occupation of the patient. No, and family history, personal history, drug history. After that, you will come to the general examination. Any doubt?
Hello, I just want to add one thing, যেটা আগের ওটোলজিতেও বলা হয়েছে, যে as you prepare your history, you should be able to justify when the crossing is done. So it is very important to judiciously jot down the, like Dr. Diptangshu said, jot down the chief complaints in the order of priority. And number 2, one important thing I think all of us would agree, that it's better to use non-medical term in chief complaint, because patient is complaining not history of epistaxis, history of nose bleeding. So, and then during the description of history of present illness, you can use the medical terms if necessary, but not in chief complaint. These are the 2 important things that sometimes the examiner, when they come from outside, they catch on you. Why do you say epistaxis? Did the patient pronounce he's got epistaxis or hyposmia? So that is one thing that you can consider writing in your patient's language, just the chief complaint. Now I invite Dr. Shubhabroto to take through the examination of the nose, relevant to nose as a whole for both the cases.
Okay. Good morning, everybody can hear me. Now all of you are exam going batch, so please remember that as a long case, When you face you are going to present the long case, he may ask you, show me your copy, what you have written. He may straight away go through what you have written. Or else he may start with, what is the summary, and you start saying summary in just a paragraph. But please remember, the most important part is the history, the crossings related to history and examination, clinical examination. What is this examination for? That you are going to be certified as a qualified otolaryngologist. So as a qualified otolaryngologist, you must be knowing all the nitty-gritties, how to examine a patient and come to a diagnosis. That is the exam for long case. So for that, the most important thing which we have already discussed is the history. Now we are going to cover the examination part. Remember, if you fail here, means if you fail to answer properly, there is no mercy in the history and the examination part. Regarding surgical approaches or very management of complications, you may not be able to answer, pardonable. But history, clinical examination, no mercy. So, with that, any nasal case which presents with like this is there is a mass in the nasal cavity, having discharge, young patient, you have already taken the history in laboratory. So, in general, any nasal case, how will you approach the patient in point-wise manner? What are the points that should start with? What we should start with examination? Number one, anyone? We should start with examination of the external nose. Okay, examination of the external nose includes the shape, size, shape of the nose, the description of the skin, whether there is any scar or swelling, anything, visible swelling, examination of the the osteocartilaginous pyramid of the nose, whether there is any external deformity, whether there is any lateral deformity or saddle nose, hump nose, etc. And next, number two, examination of the nasal vestibule. How will you examine the nasal vestibule? You have to just tip with your finger, just tip the, raise the tip of the nose. Okay, just examine the vestibule. For what for? What are the things you are looking for? There may be furuncle, and most importantly, there may be caudal dislocation of the septum. Furuncle, nasal vestibulitis, any small pathology, small tumor in the vestibule, most important, caudal dislocation. Next is the anterior rhinoscopy. I'm not going in any details, but it is a sure discredit that if you cannot describe the procedure to do anterior rhinoscopy. For example, what is the name of the speculum? Everybody knows, but let's recapitulate. What is the name? Thudicum. With which hand we should normally hold it? Left. And you insert it with the left hand. And what are the structures visible? The floor of the nose, the nasal septum, the lateral wall of the nose. Barely in roomy cavities you may be able to see the roof, but usually not visible. If there is any mass in the nose, it is also visible and has to be described during writing the anterior rhinoscopy portion. Okay. Next is posterior rhinoscopy. What is the name of the mirror? What is the name of the site? These undergraduate questions will also be asked. So what is the name of the mirror? Very good. And what is the procedure to do posterior rhinoscopy? Because we very well know nowadays most of us do not do it. And that is why it is asked in the exam how to do it. And since you are not doing it, you won't be able to tell. So please be clear that I should be able to describe how to do a posterior rhinoscopy. You need two instruments. One is the tongue depressor, one is the postnasal mirror. Okay. And what are the structures? Why do you do the posterior rhinoscopy? To examine the nasopharynx. And what are the structures you should examine look for in the nasopharynx? The guana, posterior end of the septum, posterior end of the middle turbinate, and the nasopharynx eustachian tube opening. Nothing is practically visible by posterior rhinoscopy, but then it will be asked, do you know any other, nowadays what you do to examine the nasopharynx? What are the other ways to examine the nasopharynx? Okay, we will come to it later. Yes? One is nasal endoscopy. So what are the nitty-gritties of nasal endoscopy, how to do, we'll come to it later. So examination of the nasopharynx again we will come. Next is functions of the nose. Examinations about functions of the nose. What are the functions of the nose? What is the most important function of nose? Yes.
Filtration and humidification.
Filtration. What?
So the air that we are breathing in.
Not exactly filtration. You can say protection. Okay. And what is the main function? Air conditioning. Both humidification and temperature adjustment. Means even if you are in a polar climate, as soon as it enters your nose, the super air conditioner inside makes it humidified as well as in the main body temperature, which is absent in oral breathing. Okay. If the nose is blocked, so what are the problems? Because this air conditional function is not there. And because of oral breathing, you will know if anybody has nasal blockage throughout the night and after getting up from the sleep, you know what happens to the throat. Okay, and that is the reason why even with slight deviated nasal septum and slight obstruction of the nose, people are declared unfit to go for adventure sports like climbing, etc. So that is about examination. Now how to do it? The cotton wool test and the cold spatula test. Next you must mention examination of smell. Some common substances which are just mention them, all given in the book, peppermint oil, clove oil, etc., soap, etc. The patient should be blindfolded. That is examination of smell. So till now what we have covered, number 1, examination of external nose, examination of the vestibule without speculum, examination anterior rhinoscopy with the thudicum speculum, posterior rhinoscopy with the postnasal mirror, examination of smell and examination of the airway. Okay. Lastly, then comes examination of the sinuses. Examination of the paranasal sinuses, maxillary sinus, then frontal sinus, ethmoidal sinus and sphenoid sinus. For all practical purposes, ethmoidal sinus, sphenoid sinus cannot be clinically examined. But you can examine in your clinical examination, you must look for sinus tenderness of the maxillary sinus as well as the frontal sinus. What is the exact area and how to do it, that will be asked. How do you elicit maxillary sinus tenderness? How do you do frontal sinus tenderness? That will be asked. What exact area of the canine fossa, that will be asked. Okay. Then there is some theoretical things written in books, usually not as transillumination test of the sinuses, inserting light probes in the nose or in the oral cavity for the illumination of the maxillary sinus and all. Regarding maxillary sinus, we will again have to describe, examine it, because maxillary sinus can be involved in a sinonasal neoplasm. And so when you are examining the maxillary sinus, you have to look for many things. What are the things that you have to look for? The face. Is there any facial swelling? Visible facial swelling in the maxillary area. Okay, that is number 1. Whether there is any proptosis. That is number 2. Then you have to palpate the infraorbital margin to see whether there is any breach. Examination for the sensation on the face, the infraorbital nerve area. Okay. Then examination of the teeth, whether there is any loose teeth or any swelling in the palate which may come from the floor of the maxillary sinus. And of course you have examined the nose already, so you may have an idea whether there is any mass in the nose which may also come from arise from the maxillary sinus. So what we are discussing is a general discussion. We are coming back to the case. Okay. So if there is proptosis, again you have to examine for the orbit. How will you examine the orbit? Number 1, we already mentioned visual acuity. Number 2, whether there is any restriction of movement of the eyeball. That is very, very important, because any mass through the maxillary sinus may enter the orbit and there may be lot of causes of restriction of eyeball movement and causing diplopia. Okay, so please don't forget about all these things about the examination of the facial-maxillary region. Okay. Next, what we were discussing about the nasopharynx. In the nasopharynx, you must also know all the sizes and the degrees of endoscopes which are required. What are the sizes and what are the degrees commonly? 0, 30, 45, 70 in all colleges usually this set is there. And what are the diameter? 4 millimeter is the adult and 2.7 for the pediatric. So how to do nasal endoscopy will also be asked. How to do, there are 3 passes, first, second, third passes, please go through it, okay. And what we are discussing is expected questions. This will be asked, how to do fast pass, what are the things, where do you go, what are the structures visible in fast pass? Anybody? Yes?
Sir, posterior choana, eustachian to opening, fossa abruptum, floor of nasal cavity, and sir, floor of nasal cavity, and sir, inferior turbinate. Then along the floor of cavity, nasal cavity, when you go to the posterior side, then we see the posterior nasal.
Along the fast pass, you must be going along the floor of the nose. Above is the inferior turbinate, where you will see the valve of the opening of the nasolacrimal duct. As you proceed and enter the nasal cavity on both sides, if it is an angulated scope, you will be able to see the opening of the eustachian tube, fossa of Rosenmuller. And in this way, fast pass, second pass, third pass, you must be very conversant. Look, this class is not for a lecture. Okay, this is just the points, you must just note it down. What are the expected questions? So nasal endoscopy, everything. About the scope, about the illumination, about the cold light source, everything may be asked. Because this is a very common instrument now. Now, some old school examiners, if they come and ask you that you don't have a nasal endoscope and posterior rhinoscope you are not able to do, so what are the other ways in which you can examine the nasopharynx? Because sinonasal mass, you must have to examine the nasopharynx. So what are the other ways? You can palpate it with the cooperation of the patient. You just put a tongue depressor between two jaws so that he doesn't bite your finger, and you insert your finger just to palpate for a mass or anything. That is a very bad procedure. Another thing, it has to be, may be done under, may require general anesthesia, where absolutely nasopharynx need to be examined and you are not having an endoscope and posterior rhinoscopy is not cooperating. In that case, with the help of a rubber catheter, retract the palate and examine the nasopharynx, and this procedure may require general anesthesia. So these are all the procedure. And of course, one thing I have not mentioned, if it is a rhinology case, even if you think that this is a benign case, do not forget to examine the neck. It may be a head and neck cancer case, so you must write examination of the neck. Probably in your case there will be no neck note, so no palpable neck notes. And if it is a significantly palpable neck note, you must mention it. So again I am summarizing. So there were the 6 earlier points of general examination, then examination of sinuses, rather maxillary sinus in details, including the palate, teeth, orbit, facial swelling, swelling over the bridge of the nose, etc. and nasal endoscopy and examination of nasopharynx. With that, sir, next point please. So this particular case, the mucosa is congested, okay. The inferior turbinate could not be visualized, septum deviated to the left, nasal cavity on the, it's coming, nasal cavity, then in the right side, there is a pale polypoidal mass in the right nasal cavity, pushing the septum to the left side, thick mucinous discharge. And in the left side, inferior turbinate, middle turbinate, normal. Now imagine that in this case, in the right nasal cavity, there is a mass which is so big, which is pushing the septum to the left side with thick mucinous discharge. First question is, what do you, if you have written thick mucinous discharge, what is a thick mucinous discharge? How will you describe? Why did you write thick mucinous discharge? What are the types of nasal discharge? Okay. So, thick mucinous discharge is a pathognomonic sign in this pathology which will be discussed during the diagnosis. But if you write it, questions will be, what are the types of nasal discharge you can encounter? Why are you saying it thick mucinous? That answer you give. Why are you say, when will you say that it is a mucinous discharge or mucoid discharge? কি কেউ বলবে? When the discharge is whitish and it is sticky, তা কি আমি হাত দিয়ে তো আর ধরবো না যে চটচট করছে কি না? তো হাউ উইল আই ডু, আই উইল কি করে করব? এইটা আনসার না দিতে পারলে কিন্তু ডিসক্রেডিট হয়ে যাবে পরীক্ষায়। হাউ উইল আই ডু?
We'll ask the patient to sniff it back.
She will ask the patient to do something. Anybody?
By taking it on the gloves between the fingers.
You touch the discharge and take it and fill it. With the gloves, you to চটচটে তুমি বুঝবে কি করে? You just do it with the probe, just like oral swab. If it forms a string, that is the characteristic of a mucoid discharge, okay? So, what are the other types of discharge usually possible? Watery discharge, serous discharge, blood stain discharge, or rather absolute frank blood may be there, okay? So, thick mucinous discharge is there, and this kind of question be prepared for it. And the probe test, mass was soft in consistency. Again, how do you do a probe test? What is the name of the instrument? সবার গলা আছে, চেঁচি বলো। Jobson horn probe, ঠিক আছে? তো কি করবে? You will just touch it. Then what are the types of consistency in nasal masses? Soft লেখা আছে এখানে। What are the other things you may expect? Firm or hard? Hard usually হয় না, soft to firm. Now when will you say it soft? When will you say it firm? When will you say it hard? If you remember undergraduate days, general surgery book, all written, the consistency level, soft, firm, hard, woody hard, stony hard, everything. Firm means rubber, hard means wood or stone, soft means even something softer than a rubber, okay? So this is soft, couldn't be probed all around. What does that mean? What is probe test for? Anyone please stand up, anyone. How to do a probe test, please. আরে পরীক্ষায় তো বলতে হবে, কেউ একজন বলো, দাঁড়াও উঠে বলো, ইউ। কেউ একজন বলে দাও। শুভম, ও জানে না, বলবে না।
We'll see if the
What instrument is the probe, Jobson horn probe?
Yes.
Okay.
And we will see if we can go all around the probe and from where it is arising and whether it bleeds on touch and whether it is painful when we are doing
So mass couldn't be probed all around. What does that mean?
So it gives us the clue from where the mass is arising. So
Yes, any difference? Somebody said no. Yes, of course, from where it is arising. It is not here mentioned that where we cannot insinuate the probe. Usually, this kind of polypoidal things which are arising from the lateral wall of the nose, the probe cannot be passed all around, means the attachment area we cannot pass it. Okay. And it is insensitive to touch. What is the implication?
if it is turbinate hypertrophy, then it will be sensitive to touch.
What?
When we do the probe, then whether it is painful or not, whether it is
You should not give pain to the patient, but you just say whether he is able to understand that it is touched by something. Okay. So insensitive to touch or sensitive to touch, what is the importance?
polyp will be insensitive.
Polyp
to
will be insensitive to touch
Turbinate will
and
be sensitive.
turbinate will be sensitive. So if it is a polyp, it may be insensitive to touch.
আমরা ডায়াগনোসিসে চলে আসি প্রফেশনাল
Next, with this, we come to the differential diagnosis, okay? So I invite the next speaker.
So with the history that we are getting and with the clinical examination, young lady with no history of exposure to carcinogenic agents, not a bleeding mass, insidious onset, unilateral nasal mass, unilateral nasal swelling with thick tenacious discharge, headache, hyposmia, and also which is pushing the septum to the opposite side. What is the first diagnosis that comes to your mind, differential diagnosis? Obviously, it's a polypoid swelling we have established in clinical examination. Sorry? AFRS. So I think that is the most likely diagnosis because of the, what are the points in favor? First point is age. Next is, as Dr. Diptangshu said, history of exposure to allergen may not be very reliable by the patient. And also there is no history of exposure to carcinogenic agents. There is no rapid onset changes in the patient. Thick tenacious discharge, polypoidal mass which is filling the nasal cavity, pushing the septum, everything goes in favor of AFRS. What are the other differential diagnoses that we can have are for a unilateral nasal mass? So inverted papilloma is one thing, a benign condition which can sometimes present very slowly as unilateral nasal mass in practically even a borderline age group like this. And some granulomatous lesion, very rarely, which can be any granulomatous lesion, but that should have history of bleeding and it should have a raw area which bleeds to touch and all that. So those things should be kept in mind, but again diagnosis is fairly pinpointing here. So from here we take for management, and in management I will invite Dr. Moinak. I think in the management part there is an overlap in clinical examination and management, because Dr. Shubhabrata has already mentioned about nasal endoscopy. Nasal endoscopy in our busy clinic practice, in our busy institutional practice is like an investigation. But in a Western world, nasal endoscopy is like is part of the routine nasal examination. So, but we put this in under management, and it has been touched upon. And Dr. Moinak will take you through the CT scan to reconfirm the diagnosis and take it from there.
Thank you, sir, and good afternoon to everyone. Sir, I just have one question before I start. They often have a confusion regarding this provisional diagnosis, right-sided sinonasal polyposis, whether you should add something probably benign or probably malignant regarding from the history or the examination part only.
We can have opinion of other panelists on this. Diptangshu, Shomik, the point that he has said, whether anything else should be added to the provisional diagnosis, sinonasal polyposis, because examiners sometimes, Diptangshu, any teachers, Shomenda.
Scan is not given to you at that point.
I think that is sensible, because the
if it is malignant, why do you consider it to be malignant? What are the features in favor of your malignancy? The patient has history of recurrent nosebleeds, blood-stained nasal discharge, rapid progression, pain. So there is loosening of teeth. So all these point towards a malignant one. So probably benign or probably malignant we can say. Definitely we can say, but we must defend our provisional diagnosis.
No, I think, yeah.
If it is sinonasal polyposis, then it is always benign. When I am saying it is sinonasal neoplasm, then it may be benign or malignant.
Sometimes there is polyp in the nasal cavity, looks polyp, but there may be underlying malignancy, especially in case of aged person. That is malignancy arise from the ethmoid. Sometimes that may be adenocarcinoma also. But that is polypoidal presentation. But there is only CT scan in diagnosis. Clinically diagnosed kora jay na. Clinically diagnosed kora jay. Polypoidal presentation, but underlying malignancy is there. Especially aged person.
But provisional diagnosis is based on the history, clinical finding up to before investigation. And based on that, we have deduced that this is like a polyp. And that's why if you pronounce sinonasal polyposis, probably like Dr. Soman Bandopadhyay said, that if you say probably a nasal mass, probably benign, nasal mass probably malignant, but if you say sinonasal polyposis, that question probably does not need to be mentioned. I think that's the consensus.
Mane, what sir want to say, that make it open, that you can invite questions. Suppose it is a case of benign, but you are inviting question from the malignancy, why it is not malignancy. And one thing I want to point, in palpation, when sir said sinus tenderness, there may be also eggshell cracking
crackling.
if there is an expansion for mass. So you have to also mention the anterior, you can palpate the anterior border of the maxilla or not, rim of the maxilla. Suppose it's a huge mass, there may be eggshell cracking. This point is to be added.
So as we have understood that,
Okay, sir.
yes, there is a question from
Sir,
there.
confusion arises.
Mic to the,
Confusion arises in certain cases, like in fungal mass. It characteristically it looks very angry. It looks sometimes the surface is very irregular. Fungal mass. So we are not very much sure that whether it is malignancy or benign, because fungal mass is a granulomatous mass. So in that case, it is better to make a wide diagnosis of sinonasal mass, unless it is specifically, rather apparently you can definitely make some positive points for polyp. Better not to say polyp. Better to go for mass. It is a broader diagnosis.
yeah, question?
Sir, my doubt
It's a
was
broader
regarding this only. Like in the previous case, in COM case, we got to know that how we are writing the provisional diagnosis, because examiner will definitely look at our provisional diagnosis and we will get that how we have taken the history. But sir, in the case of this particular case, in case of nasal polyposis or in case of nasal mass, sir, how are we to frame the provisional diagnosis? Like if you are writing that this is a case of left-sided nasal mass with any complication or not, how are we supposed to frame the provisional diagnosis particularly? Like we got to know that how we are going to frame the provisional diagnosis in case of COM, how are we supposed to frame the provisional diagnosis in case of this nasal?
I think that difficulty in COM, there is no gray area. There is a standard template that you diagnose that it's a chronic otitis media, you pronounce whether it's squamosal or mucosal, you pronounce whether it's active or inactive, you pronounce whether it's complicated, uncomplicated. But other things, everywhere there is no fixed template. As everyone, all the senior teachers said, that how you build up your history and how you are able to defend. So if you write unilateral right-sided nasal mass or sinonasal mass, that is also correct. But if you can justify, if I am the examiner, I will fully be able to justify, if I am the examinee, I will be able to justify that this appears to be a polyp and AFRS probably because of the history and clinical examination and finding. But as is said, if you want to be safe, you can still write a right-sided sinonasal mass. Nobody is going to penalize you for that. That's very clear.
No, just a minute. I want to add one thing. Previously, there was one opinion of thought, what sir is saying, mass. But if you are confident from the history and clinical examination, if it is, you say it is a sinonasal polyp, left-sided sinonasal polyp, and you can stand, you are confident, then nobody will ask you any question. Okay, after what you say, there will be question. But nobody will say that why are you saying polyp, why not mass nowadays at least. When we were examining, there may be chance that why you are not saying mass, what are the differential diagnoses. Sir, I am directly saying it's my provisional diagnosis sinonasal polyposis. What sir is saying correct. But if you are confident enough to stand that these are my point in favor of polyp. Sir, this is history, this is examination, so I am saying it is a polyp. It may be differential diagnosis. কিন্তু তুই যেটা বলবি সেটা অ্যাকসেপ্ট করবে
So I think
Everything will
that last word.
Last word, yes, just to say, on clinical examination and history taking, you have arrived at a provisional diagnosis, which may be a polyp, which may be anything, but that provisional diagnosis you have to justify. And lots of differential diagnosis and make it open, that it can be other things also. We have already only done the history and clinical examination. From that, if it appears to be polyp, you write it, polyposis. It appears to be a mass, sinonasal mass, doesn't matter.
Absolutely. You can always write, I will have to confirm with following investigation. And this is what we are coming
Yes,
to Tatari.
So the summary is that with the help of history and with the help of the investigations, you come to a point. Okay, then you have to corroborate whether it with the help of with the CT scan and prior to that endoscopy.
Better of it.
So to confirm the diagnosis, we will do first of all an endoscopy, as sir has told, and then followed by the imaging. Now for all practical purposes, we will do a CT scan of the nose and paranasal sinuses. This is a full form, full term. Now many of you actually fumble when you were given a CT scan. You will be not be given a CT scan during the long case or a short case, to be very honest, but it will be given on the imaging table. So whatever it is, this type of scan will not be given in the long case perhaps or a short case, but it will be given in the imaging table. So how to read? How to read? I will be very brief and cut. What are the points you should take into account? Number one is the how to start. That is the main important thing. How to start?
Computed tomography scan of the nose and paranasal sinus in the coronal section, in the axial section, showing parts of orbit. No?
Okay, carry on. Parts of orbit and
the nasal cavity along with
the maxillary sinus. Then showing.
I mentioned showing an hyperdense opacity on the left side. I cannot see the side, but
okay,
we'll mention the side in case we see it.
Okay, so the thing is that how to start. It is a CT scan of the nose and paranasal sinus. So first of all, the site, okay, whether it is right or left, you have to take into account, and then the window. Window is very important, whether it is a bone window or it is a soft tissue window. Then the cut. What are the different cuts? The axial cuts, the coronal cut, and the parasagittal reconstruction cuts. The primary cut is the axial cut. Okay, all are the deconstructed images. So actually, in the exam hall, it remains decorticated. Nothing comes into your mind. So you have to start with this. Take your time. So it is a CT scan of the nose and paranasal sinuses of the axial cut. In this particular case, axial cut, showing both soft tissue and the bone window. The above row is the bone window, the lower one is soft tissue window. Showing. Now, don't jump into the pathology first. Okay, try to see what are the normal structures. Okay, don't jump into the pathology first. Then, ideally, you should start from the coronal cut. That is the most informative cut we can take the investigations. Starting from anterior to posterior, if it is the coronal cut. If it is axial, then start from either superior to inferior, like that. Now, in case of the, you will be given only few limited diagnoses for your exam purpose. Number one is the allergic fungal rhinosinusitis, so number one DD. Secondly, it may be an antroconal polyp. Thirdly, it may be a malignancy. Fourth, it may be other neoplasm or rather mass lesions like a JNA. And finally, is a polyposis. Okay. So in all cases, you note it is mostly unilateral. So diagnostic dilemma is actually limited to the unilateral pathologies. For diagnosing a bilateral pathology, it is relatively easier. You can diagnose a chronic rhinosinusitis with or without nasal polyposis very easily. Even during the clinical examination, if you see what was the controversy all around, that if you see a polyportal changes in both the nasal cavities, in most probability it is a chronic rhinosinusitis with nasal polyposis or without nasal polyposis. So in that case, that probably benign, probably malignant tissue would not have come. So the diagnostic dilemma lies with the unilateral pathologies. So what are the unilateral pathologies we are going to see? This is the case of a fungal rhinosinusitis. You can see here it's a predominantly unilateral lesion. Okay, it's an axial cut where we can see a radio opacities in the occupying the left maxillary sinus and the nasal cavity, pushing the septum to the opposite side. If you see well that the right maxillary sinus is more or less free, it's not involved. There may be some collections in the right nasal cavity, but the lesion is predominantly on the left side. Okay. Now see here. Now see here the double density sign or characteristic sign of the fungal rhinosinusitis is a double density sign. Up to this you will be asked, then what is the double density sign? Okay. How is it formed? Ki kore hoy? Ki kore hoy? You know all these things. Nothing to bolar kichu nei. Ki kore hocche? Heavy metals. Heavy metals ki jama hocche? What is it actually?
Aggregates of calcium, magnesium, manganese around dead fungal necrotic debris.
It's a inspissated allergic mucin surrounded by hypertrophic mucosa, and it is rich in bivalent metals. Okay, that is the thing. So it is a highly characteristic of allergic fungal rhinosinusitis. To term it allergic, you have to prove it with the help of a Bent and Kuhn criteria that will come in the theoretical questions. So স্যার পরের স্লাইডে যে পরপর আছে। So the same thing, you just see the axial cuts. Okay, another thing, in the soft tissue window only, we can appreciate better the double density sign. It is not that much appreciable in the bone windows. See the double density signs occupying here in this particular case, it is extensive fungal rhinosinusitis involving both the sphenoid sinuses and all the bilateral and the ethmoid sinuses. But generally for your practical purpose, it is generally unilateral, in one side only. It's a heavily loaded disease. So next. So the same thing you can see here, the axial cuts of the same lesion. You can see in this particular case here, you can see the maxillary sinus is loaded with disease. These are all the, you can say in radiological double density sign, but aggregates of the allergic mucin containing the bivalent metals. The same thing, okay. Different cuts, you can see this is a bone window in the lower tier. You can see that double density sign is not that much visible. Anyway, let's go to the next diagnosis. Now see, again a unilateral lesion, okay, in one side, on the left side. Then again you can say it is a CT scan of the nose and paranasal sinuses, bone window showing the what? Soft tissue window, yes, soft tissue window showing what? Homogeneous is not homogeneous as per se. If you see the serial cuts now, you can see, now see. So this makes the difference between a bone window and a soft tissue window, okay. Actually the soft tissue window here you can see, this is a bone window, it's not a soft tissue window, okay. You can see the heterogeneity here, okay. This is a heterogeneous mass, okay. So it's a heterogeneous mass you can see. It is basically malignancy, okay. Difference, see, in your exam case, it is very difficult to say where the bone appears to be more prominent, okay, it's actually a soft tissue window, okay. Where the bone is actually not that much prominent, the bone walls are thinner, appears to be thinner, it's a bone window, okay. This is a bone window, this was a bone window, and this is actually in a mixture, in the Hounsfield is in between, okay. You cannot claim it to be a purely soft tissue window or purely bone window. But we can see, we can appreciate the heterogeneity here, okay. The earlier card, this one, this is a soft tissue window, okay. You can see the body markings very prominently, appears to be very, very prominently, but it's a soft tissue window. But this one is definitely a bone window, okay. Now you can say, you can appreciate the heterogeneity here occupying the maxillary sinus. See, the medial wall of the maxillary sinus is completely destroyed and it is coming, the mass is coming into the nasal cavity. You can appreciate the part of the septum here just abutting the opposite middle turbinate, but there is signs of destruction here in the anterolateral wall. Here it is bulging out and then the signs of destruction. Signs of bony destruction is best seen in the bone windows, okay. Don't go for the soft tissue window because soft tissue windows give an apparently good appearance for the bone. It's not like that. So again you can see here, see there is a almost a bulging out and then the destruction of this anterolateral wall, okay, of the maxillary sinus, and the heterogeneity you can see here. So these are basically the malignancy of the what? Maxillary sinus. Now you may supplement all these images with the help of an MRI because see, the malignancy may be there in the CT scan, okay, the primary lesion may be in the CT scan, but whether these ethmoids are involved or not, these are the collections or not, you don't know. So we may supplement this CT scan with the help of an MRI. This will give an idea about the extent of the lesion and how and future surgical planning. So to reduce the stage the disease appropriately and to plan the surgery accordingly. So MRI is also very much important, especially in case of suspected malignant lesions.
Can anyone raise your hand and tell us indication of MRI in case of unilateral nasal mass or nasal mass where CT scan has been done? After seeing a CT, this is fine. You suspect olfactory neuroblastoma, neurogenic tumor. Anything else you want to add?
Sir, if we are seeing any intracranial extension or any intraorbital extension, then we will go for MRI.
Primarily, any extension beyond the confines of paranasal sinuses. If it is destruction and expansion, extension beyond the sinus, like he has already shown, that there is sinus. So you must know the indication. পরীক্ষা কিন্তু এটা খুব strongly জিজ্ঞেস করবে. When do you ask for MRI? When do you ask for contrast? Suppose you have done a non-contrast CT of a unilateral or nasal polyp mass. When do you ask for contrast? Again.
Vascular lesion, if any vascular lesion if present, vascular lesions like
Suspected vascular lesion.
Yes, so that will
Or neurogenic lesion. These are the two indications where obviously if you have done a CT scan, NC CT scan thinking it's a polyp and it turns out to be a suspicion of a tumor, then any neoplasm you should do a contrast study, I think.
Also,
এটা আমি just
yes,
sorry
sir.
to interrupt.
No, sir, it is very
প্রশ্নগুলো ওদের না বললে পরীক্ষা এটা জিজ্ঞেস করবে তো।
because for example in this malignant CA maxilla, okay, you may have to do a contrast enhanced CT scan. Only plain CT may not do. Also, to exclude the involvement of the ethmoids, you may have to do an MRI also. Supplement this with an MRI. Now, if you go to this case, I will come to that later once we have. Now see, this is a scan or extensive scan you can see involving the, you can see it involving the nasal cavity, the right maxillary sinus, encroaching into the nasal cavity and pterygopalatine fossa, infratemporal fossa with a gross destructive lesion. Okay, the lower one, as you can see here, are the bone windows, and these are the soft tissue windows you can see. Now, this is a contrast enhanced CT scan. See, it's a contrast enhanced CT scan, and this mass has particularly taken up a huge amount of contrast. And if you see, go to the following slides, you can see here also. This is a mass involving the maxillary sinus on the right side. A little bit of ballooning is there, but it is also apparently involving the orbital cavity, and it's involving the sphenoid sinus, maybe intracranial, maybe, I don't know, because see the sphenoid sinus roof appears to be dehiscent. So there is a lot of dilemma. Why the CCT is taking up contrast? Why there is involvement, or there may be involvement of the intracranial compartment? So to conclude or to finalize the thing, we have to go for an MRI. We did not do an MRI here, but it is a case of a JNA. Okay, an extensive JNA. You can see here is a contrast enhanced CT scan of the same patient. See how it is taking up the contrast here. Okay, and it is such a huge involvement of the maxillary sinus, the nasal cavity, the pterygopalatine fossa, infratemporal fossa, the nasopharynx, and it is also going into the intracranial compartment. Appears to be. See the thing. This is a thinning of the skull base. Okay, and there may this is also the apparent destruction of the walls or confines of the sphenoid sinus. So in this particular case, we have to go for an MRI, also for a contrast enhanced CT scan. So if you go back to the earlier slide, this is very important for you. Now what is this is a very simple case, you can say now. What is how to read this CT scan? And what are the salient features of diagnosis here? These are CT scan of nose and paranasal sinus, okay? Coronal cuts from anterior to posterior. There are many jump cuts. So showing what? Showing almost a homogeneous lesion involving the left maxillary sinus coming out into the nasal cavity with a widening of the medial wall of the maxillary sinus or the osteomeatal complex. So it is a differential diagnosis ki hobe, provisional diagnosis ki hobe, but is the provisional diagnosis probably benign or it's a antroconal polyp. If it is imaging table, you have to say it's an antroconal polyp. Okay. The same thing if you go for the axial cut, you can see it very well. See how the medial wall of the maxillary sinus or the osteomeatal complex unit has been widened. Okay. So already widened, the middle metal anterostomy has been done as if. So the mass is coming out from the maxillary sinus into the nasal cavity. A classical imaging of antroconal polyp left side. This we have studied already. And finally, the bilateral case. Okay. So as I told you, if it is bilateral, it is easier to diagnose clinically as well as radiologically, because the window of differential diagnosis is very narrow. It will be either a chronic rhinosinusitis with or without a nasal polyposis. That is the only diagnosis for atio level generally. So you can see, now you describe, anyone? Describe Koro. What is the CT scan? Tell. Describe.
This is a CT scan of nose and PNS of coronal section. Okay. Paranasal sinus of a coronal section showing bilateral orbit, bilateral frontal sinus, maxillary sinus, and the in a bilateral inferior turbinate, middle turbinate uncinate process, and parts of ethmoid sinus, and showing. That's part sphenoid sinus also can be seen. Sir, that part, sir. The bilateral.
What is showing?
Showing the right side of opacity, homogeneous opacity, fully covering the right side of the maxillary sinus. Sorry, left side of maxillary cavity. Covering fully covering the left maxillary, occupying the left maxillary sinus and putting out, entering into the nasal cavity. Left nasal cavity. Most probably up. Right side is there is mild opacity showing mucosal secretions, I think.
Secretions that will come on MRI. It's a mucosal thickening apparently occupying the right side, and in both the cases the osteometrial complexes are blocked. The OMC is blocked. Okay, and to confirm whether it is a secretion, whether it is a polyp, we may go for an MRI. It's not mandatory. You can go for it. So. No destruction. You cannot see it. It is obscured by the mass. The mass is coming. In case of the malignancy, it was destroyed, yes. But generally say, there are a few points. In case of chronic rhinosinusitis, there is also fungal rhinosinusitis. Destruction or erosion doesn't generally occur. There is remodeling of the bone, there is ballooning of the bone, but destruction of a particular bone as hard as inferior turbinate generally doesn't occur. It is obscured. You can expect in case of a malignancy, maybe squamous cell carcinoma of maxillary sinus, that you can expect. But in all practical cases, especially in case of chronic rhinosinusitis or fungal rhinosinusitis, even in JNA also, destruction of the turbinates is not usually seen. Okay? And they don't cause destruction, they cause only bony remodeling, fungal sinusitis and chronic rhinosinusitis. In this particular case, what is the diagnosis? Chronic rhinosinusitis with nasal polyposis, you can say. Whether it is benign or malignant, the question doesn't actually arise. It's very evident. Okay. So, this one again, now you can see, as we are going posteriorly, you can see the posterior ethmoids now. Okay. Here you can see the opacities on occupying both the maxillary sinuses here. On the left side it is quite extensive, and on the right side you can see the mucosal thickening. These two, to further delineate whether how much it is secretion, how much is actually the polypoidal thickness, you can do a MRI if you wish. Okay. So this much about the CT scan. It will be.
So what we have learned from Dr. Moinak's description is that when you are given a CT scan to be read in your examination during your long case, most of the time you will be provided with the CT of the patient. You first need to orient what scan, coronal, axial or sagittal reconstruction. Number 2, is it a plain or a contrast scan? Are you looking at a soft tissue or a bone window? First these things should be and ascertain the left and right side. Sometimes it's not very easy to read that in the labeling. So these are the first things before you start looking at the pathology. Then whatever scans are provided, go from anterior to posterior or posterior to anterior in case of axial. Follow a pattern like superior to inferior like an axial, and then read the few scans, and then you come with a finding. Do not come with a diagnosis first. You do not want, you have to give the examiner opportunity to ask you question. Do not say this is a case of AFRS. You can say that I can see this opacity, this is so much. So when you are talking about contrast, you are expecting examiner to ask you question on contrast. When you are talking about windows, you are expecting question on that. So more hint you give to the examiner, more room you leave for things that you know. Those things you give to the examiner clue to ask you question. So you may not even go to the final diagnosis and you have scored very good marks by then. So that's the technique that I would suggest you to follow rather than jumping to a radiological diagnosis first. So this is what we have learned from his talk. I would invite Dr. Doipayan Mukherjee now. Now we have established that this is a case of allergic fungal rhinosinusitis, and he is going to talk about the philosophy of treatment, and then Dr. Soumik Das will take us through the medical treatment. Doipayan, please.
Dr. Soumik Das will speak on medical therapy. Now the question is up to this level. So this is a case of CRS, allergic fungal sinusitis or whatever may be. So the question is, what is the need of medical therapy? Because now we are in the era of functional endoscopic sinus surgery. It will be passed within 1 or 2 months, and then you will be the consultant, and after getting all those patients, we will jump to do functional endoscopic sinus surgery. So what is the basic philosophy or role of medical therapy in CRS? Anybody? Anyone, please? To decrease the disease load. Anyone else? To prevent recurrence. Then? Absolutely correct. So now it is established fact that this is inflammatory disease. So for any inflammatory disease, surgery is not for curative intent. So what is the actual role of surgery in this type of disease? Anyone? We used to do functional endoscopic sinus surgery. Why we will perform functional endoscopic surgery? Bol Ashfaq, bol, ute bol. Bol.
Sir, to make a path for the medicine therapy.
Okay.
Reduce the
Anyone else? You want to add anything, please? Re-establishment of the drainage path. Anything else?
Sir, enhance the mucociliary clearance.
Enhance the mucociliary clearance. So anything else? Application of the medical therapy. That means you are answering yourself. So for an inflammatory disease, surgery should not be done for the curative intent. If you are just wanting to do a surgery and forget about anything, there will be 100% recurrence. So what is the role of medical therapy? Number one, prior to the surgery, medical therapy should be applied, and this is a term called maximal medical therapy. So you must give this maximal medical therapy a chance for each and every patient, and it will help to regress the disease. Then it will help to reduce the amount of blood loss at the time of actual operation, and quality of surgery will be improved, because functional endoscopic sinus surgery is all about visualization, clear field. So if you are having messy field, bloody field, then your surgical process will be also hampered. So the role of medical therapy is the primary role to treat this type of CRS, chronic rhinosinusitis, because only the medical therapy can cure the disease. Surgery alone cannot cure the entire disease. So this is the role of medical therapy, and role of medical therapy should be started well in advance prior to the surgery. Pre-operative medical therapy role is to regress the disease, to reduce the amount of blood loss and better delineation of the anatomy. And sometimes if there are very small polyposis or just osteometal complex obstruction, if you can give maximal medical therapy, in many patients we may not require actual surgery also. So this is the role of preoperative medical management. Then Perioperative medical management, this is also very important. Perioperative medical management is also important for reducing the blood loss. But medical therapy should not be stopped at this point also. Post-operative medical therapy is also very important to prevent all those recurrence and for curative intent. Now, Dr. Shomik Das will proceed with the actual medical therapy.
হ্যালো শুনতে পাচ্ছিস আচ্ছা টু স্টার্ট উইথ আই হ্যাভ 2 পয়েন্টস টু মেক ফার্স্ট ইন দ্য প্র্যাকটিক্যাল এক্সামস ইউ জাস্ট নিড টু ক্যারি ইউর ব্রেন উইথ ইউ হ্যাঁ তো ইউ ডু এভরিথিং অলমোস্ট এভরিথিং জাস্ট ইউ লিসেন টু হোয়াট দ্য এক্সামিনার আস্ক try to understand what he wants and then you speak. Okay, people often tend to speak without realizing what the examiner is asking. That is very, very important. Keep cool. Most of the examiners you know because out of 4, 2 will be from your college. So you know them, you know what they ask. Other 2 can be managed. Okay, just by keeping your brain inside the examination. And about the theory, I just want to make one point. Because you are not accustomed with writing all these long questions, just time management is most important. A question, maybe you know everything about that, and you continue writing it for half an hour, and then you have only 2.5 hours for the remainder 9 questions. So make sure you manage the time well. Okay, about my topic. So as you know, we have already made the diagnosis of FRS, and this bent and cool criteria is important. The set of 5 diagnostic things like major and minor criteria. You may be asked of this. So one is type 1 hypersensitivity, nasal polyposis, the characteristic CT scan findings which Dr. Datta has already elaborated, eosinophilic mucin without invasion. That you can make out by the CT scan itself, and the positive fungal stain. That we sometimes do, we not do. And the minor one is asthma, the unilateral disease, the bone erosion may be, may not be, fungal cultures often done, the Charcot Leyden crystals and the serum eosinophil. Of course, you do that. And I will just go through 2 points about allergic fungal rhinoceros. As Dr. Doipan has already told you that the purpose of medical treatment is just reduce the burden of the disease, you shrink the polyp, and you reduce the vascularity before surgery. And about this chronic rhinosinusitis, CRS, without polyp, as you know, the medical management is the most important. So about medical management, you know what are the medicine we prescribe. Usually we give intranasal steroids, and nowadays fluticasone and mometasone are used single daily dose, preferably in the morning. And that can be continued for 8 weeks to 12 weeks. You can continue that. Along with that, sometimes the polyps are big, you can give oral steroids for a short duration, maybe 5 or 7 days, and that will take care of the nasal obstruction. And then there are other drugs that you commonly use, like anti-allergic medicine, but they are nowadays, they are mostly according to the evidence that we get, it's not very useful. You can try the leukotriene antagonists like Montelukast. They, along with the steroids, can help. But as such, as a standalone treatment, anti-allergics or this Montelukast doesn't last. So among the other medicine, you can give the immunomodulatory antibiotics like azithromycin. These can be continued. All other macrolides like clarithromycin also can be given. That can be continued for a long time, and that sometimes helps to reduce the chronic maxillary sinusitis. I will not go to the details of the drug. Another drug that can be of help is doxycycline. Okay. So that is also has anti-inflammatory action and can be given for a long time. Apart from that, there are some monoclonal antibiotics that is nowadays can be given in recurrent cases, as you know, like omalizumab. I have no personal experience about that medicine, but it is an anti-Ig agent which significantly reduces the symptoms of chronic maxillary sinusitis, rhinosinusitis, sorry. Another drug is mepolizumab. Again, I don't know much about it except that is an IL-5 receptors. But as you know, these are costly medicine. and the risk of anaphylaxis is there when you use this medicine, and they sometimes have to give subcutaneous injections, which itself is a problem. So, and another important thing that may be asked is aspirin desensitization. You know all about samtastride, which is a combination of aspirin sensitivity, asthma, and this chronic rhinosinusitis or sinusopolyposis. So here there is a role of giving an increasing dose of aspirin, and can be given for a long time and for a quite a significant amount of medicine. And this, if the patient is tolerated, that can lead to help of the reduce the aspirin intolerance. But and then reduction of microbial load. Here giving the saline nasal washes do help, especially after surgery. They can take care also of the biofilms, which are quite common, bacterial and fungal biofilms, which you, as you know, systemic antibiotics do not work much. There you have to rely on topical antibiotics, which are not very much available in our countries, maybe. Sometimes surfactants can also be used. And decongestants can be given for a short duration, like nasal drops maybe for 5 days, or if you can give phenylephrine or phenylpropalamine. Those, of course, cannot be given in elder people, and there are certain restrictions with people with heart, prostate enlargements. Those you cannot give the medicine, but in below 40 it can be given safely for a duration of maybe 7 days. And mucociliary clearance can also be helped by giving saline wash, removal of crust. This can be helped by doing nasal endoscopy and clearing. This much I think will suffice, but because this will not be much asked in an exam, we'll just give a brief overview of the thing. I think Dr. Amitabh Rajpuri will.
So I think the philosophy of management of allergic fungal sinusitis and chronic rhinosinusitis has been detailed by both the speakers. I am going to do a monotony breaker for you because your brain must be very much taxing. So we'll just go through a 5-minute or 10-minute journey into the sinuses through some videos to tell you a few basic steps which are asked in the examination for a FES. So how is FES done? What is the principle of FES? This has been already highlighted: restoration of mucociliary pathways, restoration of sinonasal patency, enhanced delivery of medication, because we have already discussed that this disease, this group of disease, this plethora of disease, they have medical treatment as mainstay and surgery as an adjunct to create ventilation, to enhance delivery of medicine and to prevent recurrences. Otherwise, if you do a surgery and don't do anything, it will recur after 6 months or even 3 months. So, striking a balance is important. I think this has been talked about. I will, because in the interest of time, we will skip some of the thing. First is we skeletonize the anatomy of the nose by doing a lot of decongestion. As you can see, this is the left nasal cavity. We are going through the osteometal complex of the left side, identifying the bulla, the uncinate process, the free edge of the uncinate process, and this space between the bulla and the uncinate is the hiatus semilunaris inferior, which leads to the infundibulum. So, the first step of endoscopic sinus surgery is opening the gateway into the infundibulum by doing an uncinectomy or sometimes uncinotomy, depending on the need of the surgery, or it is also called an infundibulotomy. So, you are opening into the infundibulum by doing an uncinectomy or partial uncinectomy. So, this is the first step, that we skeletonize the anatomy. The next step is when you have a very severe disease, again you have to skeletonize by removing the polyps. So, I am just quickly going through because these are asked in the examination. How do you do an uncinectomy? What is the landmark? So, if you have polyps like this obscuring your view of the anatomy, then you remove the polyps, taking care not to disturb the anatomy. Like you can see again on the left nasal cavity, we are preserving the middle turbinate, we are preserving the uncinate process, just clearing all the polyps to create a new anatomy which will lead you to the surgical field. Okay? So, we are just going to run through these very quickly. So what is the importance of uncinate process? As you can see, the uncinate process is a bone-like sickle shaped. This is the vertical segment which is attached here. That's the lateral wall of the nose, vertical segment and the horizontal segment. At the junction of the vertical and the horizontal segment, you have the natural ostium of the maxillary sinus. When you do your basic face, your first step is to remove the uncinate process from here at the junction of vertical and horizontal and open into the natural ostium and open into the infundibulum, which is nothing but here. So that's the first step. Complications, what you can do, you can straight away go into the lamina papyracea by causing an orbital penetration, injury to the anterior ethmoidal artery. Anterior ethmoidal artery will be here at the skull base anteriorly, and incomplete removal will lead to a failure. That is also a complication because that will close the MMA or middle meatal antrostomy that you have created. The techniques. So the first step for doing an uncinectomy is to gauge the depth of the infundibulum. This is the uncinate process that we are palpating here, vertical segment, and you will also see the horizontal segment below here, and that's the horizontal segment. So uncinate process is like this. This is the bulla, and the ball probe is going into the infundibulum through the hiatus semilunaris inferioris. And now by doing an uncinectomy from here, we are going to open the infundibulum. That's the first step. Again, polypoidal disease. You will see this is the left nasal cavity, uncinate process being palpated, where you see the attachment of the uncinate process to the lateral wall of the nose. There you can see the movement, so you know how much to remove, and then you insert a backbiting punch. That is the safest way to do. You will see in a minute. We will insert a backbiting punch, and here, because there is adequate space, we have not disturbed the polyp which is lying inferior to our operative field, and by putting the backbiting punch and making a few punches at the junction of the vertical and horizontal part, we are making the first uncinotomy, and that opens our gateway into the natural ostium, which is showing the polyp inside the maxillary sinus. So what are the important steps here? Palpating the uncinate process, understanding what is the depth of the infundibulum, delineating the vertical and horizontal segment of the uncinate process, making a cut at the junction of vertical and horizontal segment of the uncinate, and then removing part of the uncinate as the need be, and then you can reach into the identifying the natural ostium and opening the enlargement. That's the inferior part of the uncinate process which is being removed. What are the cautions? I think we have already talked about. If you have an atelectatic infundibulum, we can straight away go into the orbit, and we should not strip the mucosa. So now, after doing an uncinectomy, this is a middle meatal antrostomy. You will see that this is the middle meatal antrostomy being done, and there are cysts inside the left maxillary sinus here, and by removing the uncinate process vertical and horizontal part, you can do the natural ostium. Now, what is a natural ostium and what is a accessory ostium? The natural ostium is a natural drainage where the sinus, maxillary sinus mucociliary clearance is genetically predetermined to go there, and accessory ostias are slits on the fontanelle. Fontanelle is an area in the lateral nasal wall which is devoid of bone. If you see a skull, the middle, the infundibulum area is huge, but in a live body, the infundibulum is very small. Why? Because there are areas where there is no bone in the lateral wall, but only mucosa. That's fontanelle. And natural ostium is in the middle. Anteriorly, you can have anterior fontanelle. Posteriorly, you can have posterior fontanelle. And when there is an accessory ostium present, you will have to join these two. This is natural ostium here, and this is an accessory ostium. How do we know? You will know in a minute, because natural ostium is a funnel shaped 3-dimensional opening, and accessory ostium is just a slit, as if there is a curtain and somebody has made a cut on that cloth. That is an accessory ostium, and natural ostium is like a funnel. So you need to join these two by palpating. You can see this is the 3-dimensional structure going deep into the maxillary sinus, and this is just a small slit here. So these two ideally needs to be joined, which you can see here in this video. all these small clips I am showing because these are the questions that normally examiner will ask you, very basic questions. So we are just joining these two ostia, natural and accessory, to make it a wide middle metal antrostomy, and this is the horizontal part of the uncinate process, which you can see I am dissecting submucosally, preserving mucosa and then removing the thing, making the middle metal antrostomy more wider and enlarged to see the polyp inside the maxillary sinus. So what instrument you use does not matter, nobody is going to ask you, but basic instrument is a backbiting forceps punch and a Blakesley Weil forceps, sometimes a scissor, and obviously plus minus a micro debrider. So that's the maxillary antrostomy created very nicely. Complications, if you go too much superiorly, you are going to go to the orbit. If you come too much inferiorly, you are going to damage the inferior turbinate. If you go anteriorly, you are going to damage the nasolacrimal duct. If you go too much posterior, you will get to the sphenopalatine artery and damage, cause a heroic bleeding. And circumferentially, we are not supposed to strip the mucosa of the natural ostium, because that can cause a cicatrization and therefore physiological failure of the surgery. Anterior ethmoidectomy, I will just quickly go. What is anterior ethmoidectomy? Nothing but puncture the bulla, remove the bulla. Bulla is the largest anterior ethmoidal cell and the most consistent anterior ethmoidal cell. So you remove that in various methods, and that completes your anterior ethmoidectomy. Sometimes bulla can have a suprabular space or a suprabular recess or a suprabular pneumatization. So you need to understand that in the CT scan, and accordingly you do justice to that. So here is bulla penetration from forward. That's the bulla. This is the bulla, and we are just penetrating from forward to backward, making sure there is a lumen here and there is a cell, and we can go and remove this whole cell. That's one way of doing the anterior ethmoidectomy or removal of the bulla. The second way is suction, forget it. You can go and remove the bulla in a retrograde way. We are going behind the bulla because there is a retrobular space here, and removing the bulla, that's a very safe way to do, because you are not going to go beyond the anterior ethmoid. So just remove the bulla from a retro, just go behind the bulla and remove it with a curette or whatever instrument. So this is a very safer way to do the bulla or anterior ethmoidectomy. Again, the cautions are almost similar to what we said. Injury to the lamina papyracea, injury to the anterior ethmoidal artery, which is lying here, and coming to the posterior ethmoidectomy. We have done the anterior ethmoidectomy, same specimen, left side. There is an additional pneumatized cell here, and this is the middle turbinate. So middle turbinate is now turning obliquely towards the lamina papyracea, and that's the second third of the middle turbinate, second 1/3 of the middle turbinate, which is the ground lamella or the basal lamella, which forms the boundary between the anterior and posterior ethmoid, and you just puncture that, you go from anterior to the posterior ethmoid. So quickly, this puncture of the ground lamella will let us enter into the posterior ethmoidal cell, and there will be multiple posterior ethmoidal cell, and we will have to go cell by cell to clear all the posterior ethmoidal cell, preserving the mucosa. It's not possible to show the whole surgery, I am just showing you clips so that this is all relevant to your examination questions that may be asked in the oral. Coming to last but not the least, sphenoidotomy. Sphenoid, as you know, can be reached either through the natural ostium of the sphenoid, which is called the median approach, or through trans-ethmoidal cavity after doing posterior ethmoidectomy, which is called the lateral approach, or you can go intermediate approach, which is by going trans-ethmoid and then going again through the natural ostium, which is a safer option. So I will quickly show you all the three. This is left side median approach, means going through the natural ostium. Where is the sphenoid sinus ostium located? Can anyone tell me? Anatomically, when you do endoscopy from choana, everyone knows 1.25 centimeter above the free edge of the choana, you have the sphenoid sinus. Probably you missed it as I was talking to you, I will show you again. So identify the natural ostium, enlarge it, as simple as that. But this works only when you are doing isolated sphenoidotomy, because you are not disturbing anything else and you have made a wide opening into the sphenoid. So that's the median approach. Then you have the lateral approach, which is the same, like we said, that's an ethmoidectomy cavity performed. You go posterior-inferiorly, not here. If you go like that, you will go to the skull base into the brain, and you can just enter into the sphenoid sinus. This is called the lateral approach of the sphenoid sinus, as you can see by going and poking into the posterior inferior part of the posterior ethmoidal cavity, breaking the anterior face of the anterior sphenoid sinus. That's the interior of the sphenoid sinus, where you can see the optic nerve and other bulge of the optic nerve and the intersinus septum and other areas. Okay, that's the bulge of the optic nerve. And the last but not the least is intermediate. This is my last this thing. So again, ethmoidectomy done already, and all the polyps are being removed from here. It is nothing but we are still going to go from the posterior ethmoid towards the superior meatus and then locate the natural ostium of the sphenoid sinus. This is a case of AFRS, I think. You can see some fungal debris coming out from there, and then that's where the sphenoid sinus will be lying. I am sorry I can't show you all the details because of paucity of time, but at least you have got a grasp of the basic steps of the face, and this is the minimum which will be asked in your examination, including the complication. Okay. So with that, we would end this one. We would quickly go, before we close down this case, final comment.
So when you are seeing a operation from a master, everything will be very smooth. Now for examination purpose, what are the crux? Which questions can be asked at the time of your examination? So first is, you can comment about anything in the entire procedure of functional endoscopic sinus surgery. The easiest part, which one is you are thinking the easiest part? Uncinectomy, no? Anyone? So Amitabh will agree, most of the complications are usually happened at the time of uncinectomy. So this is the question. So what precautions you should take at the time of uncinectomy? Because see, the uncinate attachment is different, and sometimes this infundibulum is very shallow or narrow. So without knowing anything at the time of uncinectomy, anybody can enter into the orbit. So which precautions should be taken at the time of uncinectomy? Number one, as Dr. Raichaudhuri said, first you should palpate and you should have a clear idea regarding the depth of infundibulum. Then outfracturing it, and then you can use whatever you like, sickle knife, backbiting, whatever you like. But the crux is the upper attachment of the uncinate, because the uncinate can go like this, uncinate can go like this in the base of the skull, or uncinate can move like this towards the middle turbinate. So at the time of removal of this upper part of the uncinate, we must be very careful, because this is required to approach frontal sinus. So your movement is of the instrument, the cold instrument is very important. So in the lower part, it is always better to make it anti-clockwise, so that there is no tear in the mucosa, and in the upper part it must be clockwise. Why? Because there is chance of no, I am talking about only this case. So this is very important. Next, what is the most important philosophy of functional endoscopic sinus surgery? To keep the mucosa intact. See this operation of Dr. Raichaudhuri, he was trying his level best to keep the mucosa intact when he is trying to enlarge all those osteums. Why this is important? Anyone? Huh? So the most important thing is, if you are stripping the mucosa, there will be exposed bone. So there is chance of osteitis and biofilm formation, and healing will be delayed, more crusting. But this intact mucosa at the time of making all the osteum bigger, it is always helpful to restoration of the mucociliary clearance in earlier stage. Next, you can see the base of the skull. Base of the skull is like this. So next important point is, when you are entering deep inside the nose, always try to negotiate your endoscope like this, because this is our base of the skull. So you can just entering into the nose like this, most likely you will injure the base of the skull. And lastly, as Dr. Raichaudhuri said, that when he was approaching sphenoid sinus, how he can approach this sphenoid sinus? In which direction? Huh? Inferomedially. Why? Why? Huh? So, all the important structures is basically present in the lateral wall. Not only carotid artery, but the optic nerve, and they are converging like this. So, when we are entering into the nose, our scope and instrument should be like this, and when we are entering deep inside, we must be away from the lateral wall. Otherwise, there is chance of inadvertent injury to the optic nerve and internal carotid artery. So, these few points are very important, and I will take 2 minutes and will suggest, most likely we are in the era of functional endoscopic sinus surgery, but you don't know who will be your examiner. There may be some senior examiners, those who were doing their Caldeau-Locke operation. And in this era of functional endoscopic sinus surgery also, once upon a time, maybe once or twice in a year, we may also perform Caldeau-Locke operation. So, some basic steps of Caldeau-Locke operation should be read, and as you all know, this is the time will not permit to say each and everything. Incision will be given in the sublabial groove and away from the canine eminence. Then you have to elevate the mucosa, and you will reach the anterior wall of the maxillary sinus. Then you have to make one opening in the anterior wall of the maxillary sinus. When we will open this maxillary sinus and will make a bigger opening, we must keep 2 points in mind. If we are making this thing in much lower direction, it will cause damage to the root of the teeth. And if we are making it in much higher level, then obviously there is chance of infraorbital nerve injury. So we must be very careful. And in previous occasion, original Caldeau-Locke operation, they suggested that we should go for inferior meatal antrostomy. So what was their philosophy? That in Caldeau-Locke operation, the basic principle is completely different. We have to scrape all the mucosa along with polyps and everything from the maxillary antrum. So their philosophy was there that when you are scraping everything, you must give some nasal pack, and it will take at least 4, 5, 6 months time to regenerate this mucociliary clearance. So they used to put this nasal pack through inferior meatal antrostomy and give sinus wash through this. So that was their philosophy. But now we can understand that maxillary sinus drainage is not a dependent drainage. So the maxillary sinus ostium is in the upper region, and prerequisite of forming antroconal polyp is the enlargement of the maxillary sinus ostium. So right now we can give pack through this route, and we can give all the wash and everything through angle endoscope. For that reason only, in present day scenario, we are not going for this inferior metal antrostomy. But if you are facing some senior examiners, then they may ask this question related with Calderon-Lac operation. So please go through this so that you can answer all those basic questions.
Thank you. So with that we come to the closure of the case that we have discussed completely. I think if there are any other queries in your mind, we can still discuss at lunchtime. I think A to Z everything has been discussed as far as the nasal case is concerned, including AFRS and CRS. We also had a second case of malignancy to be discussed. So what we will do, we presume that if the first case that we had discussed, history and everything has been discussed, if that case turns out to be a malignant tumor, what will be the approach? So for that I invite Dr. Shubhabrata Sengupta first, and Diptangshu and Moinak also. So three of them will together go through between them. Quickly.
Already we have said that there are some extra points like bleeding from the nose in history, and on examination there may be diplopia. You have to, for the ocular muscles, and you have to test for in front of the examiner, might be, if it is a short case, examine the eye. So you have to test in front of the examiner how to examine the movement of the ocular muscles, as well as the visual acuity and the field of the vision. This is the extra point. And suppose next is, examiner will say what you will do. Now it is a sinonasal malignancy, what you will do. So your first answer should be, sir, I will confirm my diagnosis by doing a nasal endoscopy, because nowadays it is a OPD procedure. So I will do a nasal endoscopy. It may be under local anesthesia with proper topical anesthesia you can give, but this preparation, some examiner will ask that in OPD setup what you are doing. So after nasal endoscopy, what will the advantage? First I will confirm my diagnosis, it is a sinonasal mass, what is the extent, and what will be my approach if I am going for the endoscopic assisted surgery. So endoscopy helps in 3 to 4 ways. Now coming to the treatment, the Shubhabrata sir will say.
Examination of neck and cranial
Examination
nerve.
of the neck and cranial nerve. Obviously, if there is an extension in the where infratemporal fossa, there may be the involvement of the different foramina in the skull base. So what are the cranial nerves that can be involved? So you have to know. These all are theoretical, but a cranial nerve examination should be mandatory in case of a sinonasal neoplasm. And neck examination, palpation of neck. Then you will go for the biopsy. After biopsy, before biopsy, sir, I will do a contrast enhanced CT of the nose and paranasal sinus. If I suspect there is a soft tissue lesion which can involve the intracranial, intraorbital portion, I may go for a MRI. Then I will go for the biopsy, and after that there will be definitive treatment. Moinak, will you add?
Start.
So if the differential diagnosis includes a malignancy, or your provisional diagnosis is malignancy, so these are our treatment options. So surgery, radiotherapy and chemotherapy. The majority, the main treatment of choice for majority of lesions are surgery. Now what are the principles of surgery? These are the things which are asked. Review of the adequate biopsy material, multidisciplinary board decision in all oncosurgical procedure. It's a team. Potential surgical options including no surgery, exact tumor staging, and that depends on imaging, endoscopy as well as imaging examination under anesthesia. When it is inoperable, this is common to all head and neck cases, not only sinonasal mass. If the pterygoids are involved, its skull base is eroded. If deep extension to roof and lateral wall of nasopharynx and eustachian tube, direct extension to neck disease to skin, it is not an absolute contraindication. Direct extension to mediastinal structures, prevertebral fascia and vertebra. Presence of subdermal metastasis. I would not say these are absolute contraindications, but your resectability options Whether it is going to, the patient to land up in further trouble, depends on those. Most importantly, 1, 2, 3, 4, 5, 6, these are in nutshell. What are the principles? En bloc resection. En bloc means total resection with the tumor, and if neck is also combined, the neck resection is also attached with it. Adequate resection means 1 to 2 centimeter from the gross tumor, 1 to 2 millimeter for glottic tumors when it's a partial laryngectomy. Oncological margin, that is the oncological margin, okay? Greater than or 5 millimeter is adequate margin. What is, that is the resection margin, and this is the oncological margin. Difference is histopathological, okay? 2 to 5 millimeter is a close margin, positive margin. What is a positive margin? It is defined as carcinoma in situ or invasive carcinoma at the margin, okay? When a nerve is functional, effort should be done to preserve it. Direct nerve infarction or preoperative paralysis may require resection and nerve grafting. Another thing, please note down, which is not included in the slide, that is head and neck not only is resection but also about reconstruction. Nowadays reconstruction is mostly microvascular, okay? So microvascular reconstruction means you have to, when you are resecting, you have to keep the arterial stumps, preserve the arterial stumps and veins as much as possible, so that it will be helpful for the plastic surgeon to put a microvascular flap. Now, what do I mean by that? For example, when we are doing a neck dissection, we are resecting the submandibular gland. We resect the facial artery as such. Now, when you are planning for a microvascular, say you are doing a mandibulectomy, microvascular flap you are planning with fibula, the facial artery has to be preserved, and the length of the facial artery which you are preserving will be helpful for the plastic surgeon to plan his flap in the next sitting, in the same sitting, in the next procedure. Understood? So that is another thing of the principles of the surgery. Now, management of neck. What about the neck? This is a maxillary tumor or ethmoidal tumor or nasopharyngeal tumor if resectable. How will you manage the neck? Neck management includes N0. Clinically and radiologically N0, oral cavity, oropharynx, hypopharynx. So these are all about general discussion. If it is sinonasal mass, if only it is N1 to 2AC or N3. So in N0 neck, usually we may not go for a selective neck dissection. But if it is N1 to N3, then neck is also combined. Now, what are the surgical approaches in rhinological malignant masses? Lateral rhinotomy, these are the incisions, Weber-Ferguson approach, midfacial deglassing, craniofacial approach, endoscopic approach. This is the incision for lateral rhinotomy. This is the extended Weber-Ferguson when you have to resect the eyeball also. This is mid-facial degloving, means the incision is given in the labial crease below gingivolabial sulcus, and the soft tissues are raised above the facial skeleton. Craniofacial resection is usually combined with a neurosurgeon. So type 1 to type 4. We are not going into much details. This craniofacial resection, ideal case is a cribriform plate malignancy where you have to remove along with the anterior skull base. Most importantly for your level, definitely maxillectomy. Maxillectomy is routinely done in all the centers, and maxillectomy, what are the types? These are medial maxillectomy, infrastructure, suprastructure and total. So depending on medial maxillectomy, the lateral wall of nose is removed, infrastructure, the palate and surrounding, suprastructure, the orbital plate and part of it, keeping this alveolus intact, and total maxillectomy, whole of the maxilla along with the, just keeping the orbital periosteum intact. What are the cuts? This is one cut, second cut through the differentiating from the palate. Here you see through the orbital margin, through the zygoma, and here the cuts. These cuts you have to describe. I am not, there is shortage of time, I am not describing in details. please do not forget to describe the cards, read the cards in details, that will be asked. They may not ask you about craniofacial resection, but maxillectomy must. So radiotherapy is, we'll discuss it later. Chemotherapy I'm just skipping. So what are the things that, what are the concepts? How will you manage? So if it is a malignant mass, these things you try to keep in mind. What is the pathology? It may be squamous cell carcinoma, lymphoma, adenocarcinoma, minor salivary gland tumor, esthesioneuroblastoma, undifferentiated carcinoma, or small cell carcinoma. Okay. So these are the histopathological types. This can be, or it can be mucosal melanoma, sarcoma, or lymphoma. So these are all one side, and melanoma, sarcoma, lymphoma in the other side. Now we are discussing about the more common things, starting from squamous cell carcinoma to small cell carcinoma. It can present in these three ways. Either it is newly diagnosed, or diagnosed after incomplete resection, or it comes with a metastasis. Okay. When it is newly diagnosed T1 or T2, not going in details what is T1, what is T2, you have to remember, and they may be asking. T1 and T2, primary treatment is surgery, may be combined with radiotherapy. If it is T3 or T4A, surgery if it is possible or preferred, concurrent CTRT or chemotherapy. Newly diagnosed T4B, concurrent CTRT, CT or palliative. So as we are upstaging, the chances of feasible surgery are less. So adjuvant treatment may be radiotherapy or concurrent CTRT. So this is what when you start with adjuvant treatment. Radiotherapy, concurrent CTRT, if there are adverse features. So what are the adverse features? It may be positive margins, or the mass may be close to cribriform plate, high grade tumor involving the orbit, adenoid cystic carcinoma, perineural lymphovascular invasion. So if your provisional diagnosis or differential diagnosis, one of the things is sinonasal tumor. The main thing that as an ENT surgeon you will be asked about the surgery, radiotherapy, chemotherapy, when it is required, what are the types of surgery, maxillectomy total, and the concept, when will you do it. So what about, we are discussing only newly diagnosed tumor. In your long case, a previously unoperated case will not be given. So T1 to T4, please remember this slide, and when this adjuvant therapy is required. Most importantly, what is the feasibility of surgery, resectability of options of the surgery, when it is operable, when it is not operable. Okay, I invite the moderator, Dr. Chowdhury, to conclude the session.
So we thank you for giving a brief overview of the management. I now invite Dr. Deeptangshu Mukherjee and Dr. Moina to take you through the last part of today's session, our rhinology session, which is discussing the maxillectomy specimen total, and maybe any relevant questions. Specimen, Moina? And whatever relevant questions are asked during your specimen, both of you, with that we'll, ekhane, you'll focus it here. Oh, focus korbe ekhane.
How to hold it? First of all, you have to hold it in the anatomical position, okay? After surgery, how it looks like. So you have to hold it, or it will be kept in the table, okay? But all on the table. So place it in the anatomical position. How it is erected. Eta hocche, now tell me what is the specimen. Specimen of, what is this? A right-sided total maxillectomy, okay? Why total? You can identify the different structures. You can see the alveolar process here containing the teeth along with the palatal process. Here you can see the palatal process, the anterolateral wall, and part of the frontal nasal process of maxilla. You can see here, okay? And also you can see the pterygoid muscles here in the posterior part behind the maxillary tuberosity. You can appreciate the maxillary tuberosity just for your education purpose, just holding it. You should not hold it in this way. So you can see the maxillary tuberosity here, just behind is the pterygoid muscles, okay? So that is the, you can appreciate it. see the alveolar process here, and and you can appreciate the muscle hanging that is up to the posterior limit of the maxillectomy specimen, showing the pterygoid muscles. Okay. So, this is a specimen of total maxillectomy of the right side. Now, where is the mass? You should have an indication for doing a maxillectomy. The mass you can see, this is occupying the maxillary sinus in this region. See, there is no sinus you can see. Okay, the sinus cavity is completely full in this region. There should be a hollow, it is not there. Okay, the entire thing is filled up with mass. Probably this was a mass. Biopsy came to be a squamous cell carcinoma for which it was done for a total maxillectomy. Now we will be asked regarding the, it's over, now the questions will come. Questions will be mainly the theoretical questions. What are the different types of maxillectomy? The questions generally asked different types of maxillectomy. For this particular case, what is the indication for maxillectomy and the cuts. Okay. The soft tissue approach has been already covered. Now the cuts of the maxillectomy, total maxillectomy. Okay. Now what are the cuts of total maxillectomy? There are 5 cuts in general, 5 cuts. 5টা cut. Kiki cut ache, you know all these things. Just for recap. What is the first cut? The frontal process of maxilla is actually broken here, but you can see it, you can appreciate it in that area. Okay, you can appreciate the frontal process of maxilla. Anyway, what is the first cut? There are many controversies regarding the first cut. Is generally we make on the infraorbital margin in the lateral most part. Okay, in the infraorbital rim, actually in the lateral most part, generally always lateral to the maxillary sinus cavity. Okay. First of all, see the corroborate with the CT scan. Okay, the cavity is there, the maxillary sinus cavity. Just lateral to it, the cut should go. It should not go through the maxillary sinus cavity. Suppose the mass is here, you can see appreciate the mass here. It should not go through the mass. Okay, that is, it should take out the entire tumor within a box. So the first cut is at the level of the infraorbital margin, infraorbital rim, in the lateral most part in the zygomatic buttress, lateral to the cavity of the maxillary sinus. Okay, the first cut. Now you make it deeper and go in posteriorly and medially up to the infraorbital foramen. Okay. Now infraorbital fissure. Sorry, infraorbital fissure. Now you the second cut. What is second cut? The second cut is made at the level of the frontonasal process of maxilla. Okay, just a few millimeters below the frontoethmoidal suture line. Just a few millimeters below the frontoethmoidal suture line. Okay, so as to protect the anteroethmoidal artery coming out. So there is a high chance of damage to the or injury to the anteroethmoidal artery. To prevent it, you just go a few millimeters below the frontoethmoidal suture line. The third cut is along the lamina papyracea. Okay. Now during this process, you have to retract the orbit, the content of the orbit laterally and inferiorly. So you retract the orbit carefully and make the third cut, which is again along few millimeters below the inferior to the frontoethmoid suture line, again ultimately directed posteriorly and laterally in the level of the infraorbital fissure. Okay. So first, second and third. The fourth cut will be along the alveolar process. Okay. If it is a unilateral lesions, mostly it is not coming out into the nasal cavity. The fourth cut will be in the alveolar process where just paramedian position. Okay, you mark the philtrum here, the median incisors. Okay, just lateral to it you have to make a cut. You may have to take out one tooth. Okay, and go along the this fissure, that socket, so that the soft tissue closure later on becomes easier. So you now deepen it posteriorly along the okay, you now go along it posteriorly along the hard palate. This is not the hard palate, this is the hard palate. You can see this cut has been done. This part. Okay, this is just in the paramedian position of the hard palate. You just extend it posteriorly. So it is a palatal cut. This is the fourth cut, and the final cut is in the take out the mass, the entire box, the maxillary sinus specimen, the maxilla actually,
from its attachment to the pterygoid plates. That is by the medial and the posterior card directed laterally, making a rocking movement. Okay, just rock it with a breast. We use a very stout instrument called the Bristow's key ball. Okay, forceps. No, it's not a forceps. So what is the term is called? Bristow's we use that rocking movement. We call it Bristow. The term. It's you can use anything, a very stout scissor or something. Okay, you can just make a rocking movement. Okay, and so that the entire maxilla comes out from its attachment from the pterygoid plates. The first, second, third. The third one actually is just below, along the lamina papyracea. Third card, along the lamina papyracea, just a few millimeters below the frontoethmoidal suture line. Okay, so that the margins of the anteroethmoidal artery and the posterethmoidal artery are spared. Okay, just at the level of the posterethmoidal artery, go down and laterally, inferiorly and laterally to directed towards the infraorbital fissure, where the first cut was made. It is joining the first cut. So first, this is the first cut. This is the first cut. Okay, this is the first cut, second cut, third cut. So the third and first cut will meet together. Okay, at the end of the infraorbital fissure. Then the fourth cut. Fourth cut is in the palate, hard palate. Go deepen posteriorly. Deepen posteriorly till it reaches the postural limit of the hard palate. Okay, and then remove the entire structure from the attachment with the pterygoid plate. Okay, এই হচ্ছে তোমার মোটামুটি the bony cuts of the total maxillectomy. Now total maxillectomy cannot be done if this pterygoid muscles is involved. Okay, it is a contraindication for total maxillectomy if the pterygoid muscle is involved by the malignancy, because we will not get a tumor-free margin. That is a different thing, but this is the outline.
Thank you, Dr. Moinak. So with that, we come to the end of rhinology session. Please raise your hand. Jara mone korcho it has been useful morning. Okay. So I think in addition, this PG orientation program has not been about teaching you, but for preparing you to face the examination, to read for the examination. Dr. Snehashish Burman will say about some logistic issues. So I'm sure this will help you prepare better compared to previous years' didactic lectures that we used to have.
We have provided one Google form link for the feedback in the group. Take your time, give your feedback. There are options for your questions. You can ask questions which will be answered tomorrow by our faculties. So you can ask your questions, and also there are feedback whether the program is useful or not, and your suggestions are invited so that we can improve and give you better service. Okay. There will be lunch break now. Finish your lunch as soon as possible.
After the lunch, the CA tank session will be start. Okay. Please go for the lunch break.